The streaming.
Okay, it's coming up.
So happy to see you, Toyin.
What do you say?
I said, I'm so happy to see you. We haven't actually seen each other for a long time or view, you know,
Oh.
Zoom or anything.
All right. Dr. Hoovergard, how are you?
Good, glad to see you.
Wow. Today is my wonderful day. Nice to see you.
Did you say
Right,
today was
so-
your birthday?
No, my wonderful day, because I can see everybody.
Oh, okay.
Yes, it's a great day. Yeah, you can sing, oh, happy day, oh, happy day. Yeah, it's happy day for women because this is Women's Health and Women's Month. So we are
That's
celebrating
correct.
all women. Yeah.
Right.
All right, so please, ladies, give me a second. I know we're gonna start in a minute. I've been on Zoom like since 4 a.m. from one conference to another. So I just need to, I will be right back.
Good evening. It's 4:05, Dr. Toyin. So did you don't want to get started?
Yes, ma'am.
Okay. Hello, everybody. Awesome. Hello, everybody. My name is Portia Zaire, and I am the Global Secretary and Program Coordinator for 1,000 Women in Religion for Global Peace under the direction of Dr. Toyin Lawal, who is the host of this wonderful event, Implementation of Telehealth to Improve Women Health and Wellbeing, as a side parallel event to the UN CSW 66. It is my honor and my pleasure to introduce you to Dr. Toyin Lawal, and I will be your moderator. So immediately when she's finished, you will hear from me.
Thank you so much, Masha Portia. Thanks, everyone. Greetings, and welcome. Happy Saturday, happy Women's Month. I am so excited and so honored to have all of you here on this Saturday afternoon and also morning or evening, wherever you are. Greetings, everyone. I'm grateful to all our speakers and panelists for your time and support. And thanks to all attendees for making time to attend this program. I welcome everyone. This year, United Nations Campaign on Status of Women 66. It started from 1 and this is year 66. The priority theme for this year is achieving gender equality and the empowerment of all women and girls in the context of climate change, environmental and disaster risk reduction policies and programs. And we women of 1,000 Women in Religion for Global Peace knows that, take this very seriously. UNCSW 66 has brought to light the examination of the challenges and opportunities for achieving gender equality and the empowerment of all women and girls in the context of climate. But you might be thinking, oh, the theme is about climate. Why are we doing health? It's because, part of the solution to the problems that changes in climate brought is climate change brought climate emergency. And in this context, women are more impacted in the areas of health. A lot of women go through anxiety, they go through trauma. And for the vision of 1,000 Women in Religion for Global Peace, post-2015 agenda, we are now looking at how we can take care of the health of women. With that being said, Tabernacle Worship and Prayer Ministry, with 1,000 Women in Religion for Global Peace, a platform to accelerate the 2030 agenda. So we build momentum for effective implementation of SDG goal number 3, which is good health and well-being, to all women, both women and girls. So in this context, 1,000 Women in Religion for Global Peace initiated Telehealth for the health of women across a couple of nations. And I will give an example of the initiative and the project that we have done in Nigeria and in India, implementing telehealth. And we have honorable great speakers today who will be helping us to navigate, the context of health of women. This is an empowerment section. We will also want to use this opportunity to develop advocacy and to provide more training and more toolkits about telehealth across the globe in order to help the Peace Pathway programs for women and girls in the world. Thank you so much. Masha Portia, you'll be sharing the video on our telehealth implementation. Please ride on with me to watch this video. Thank you and welcome.
Tabernacle.
Okay, I'm gonna share my screen here so that we can get this video going. And if somebody can just let me know if you can see and hear.
Tabernacle Worship and Prayer Ministries 1,000 Women in Religion for Global Peace Initiatives through the leadership of Dr. Tony Lawal as the global president, implemented telehealth as a vehicle of delivery for Sustainable Development Goal 3, good health and well-being. The implementation of telehealth services by Tabernacle Worship and Prayer Ministry is in line with the healthcare set targets of the United Nations SDG Goal 3. This is founded on the mission that ensuring healthy lives and promoting the well-being at all ages is essential to sustainable development. Telehealth increases health access to those in rural areas and those with limited resources. The following are the evidence map of the implementation of our telehealth initiatives. Connected care for widows everywhere. Proactive calls to the patients. Access to care for the elderly and rural women. Mental health awareness through psychosocial care. Empathy and stress reduction and quality sleep education. Telehealth toolkit. Physical screening, vital signs, nutrition, prenatal care and medication management. Your Body, Your Right awareness campaign on family planning and prevention of teenage pregnancies. Breast scanner for breast cancer screening. Body, soul and spirit care bundle. Digital health data management. The project improves the health outcomes and social economic status of widows. Evidence has shown reduction in blood pressure levels, depression, isolation, increasing access to healthcare, and providing funds to seek health services. Telehealth implementation led to positive change in wellness behavior, better communication with healthcare providers, increase in psychological well-being, energy, and positive self-rated healthy outcomes.
Thank you so much, Masha Portia. Thanks, everyone. I hope you enjoyed the video. I'm here for any question. Thank you. Over to you, Masha Portia.
Awesome, thank you. That was a wonderful video, and you are a wonderful leader. I am so honored to be a part of this program, and I'm so honored to be able to introduce our first speaker of the evening. And before I do that, I just want to make sure that Dr. Ada Okika is not in the Zoom room waiting for me. Okay, awesome. So our first speaker is Dr. Patricia Etheridge. She started her nursing career in Canada as a diploma nurse caring for oncology patients. After immigrating to the US, she immediately began to work on her bachelor's degree, obtaining her foundational classes at Grand Canyon College. At the same time, she started working at St. Joseph's Hospital and Thunderbird Hospital as an ER, CCU, and NICU nurse. This was followed with working in home infusion, where she cared for both adult and pediatric patients in a variety of clinical roles. Later, she moved to hospice nursing. Thank you for your service in that area. A few years later, she found herself at pharmaceutical companies where she spent the majority of her career. That role required her to provide scientific and clinical support for the medicines that they created. Over the past 20 years at AstraZeneca, her clinical experience focused in oncology, cardiovascular, respiratory, vaccines, and rare disease states. She has participated in launching 16 new medicines for patients, and this was achieved by aligning clinical support to AstraZeneca's strategic direction, thus ensuring access to the right medication for the right patient. She worked in the healthcare community both regionally and nationally with managed care organizations, health systems, state health departments, departments of defense, and Indian Health Services. This experience has provided her an in-depth understanding of pricing dynamics, which is a big thing, and the impact of public policy on healthcare coverage decisions. Her passion is working with the underserved in communities and ensuring patients that are treated with dignity and have access to quality care. Her research focus is in theory-driven behavioral educational interventions using technology. Today, she works as a university faculty member in a Doctor of Nursing practice program, helping students to develop a spirit of inquiry, thinking critically, being innovative, and leading the healthcare community in ensuring the best outcomes for their patients. Her hope is that her students can successfully complete clinically relevant projects that provide the best clinical patient outcomes, advance the nursing science, and disseminate the knowledge gained. Please join me in welcoming Dr. Patricia Etheridge. And I am going to share her slides. Oh, you're on mute. You're on mute, Dr. Etheridge. We can't hear you. You're on mute. Let me see if I can unmute her.
I'm unmuted. Well, I was talking away, so thank you. Thank you, Portia and Dr. Lowell, for that introduction. Much appreciated. Good afternoon, participants, and I want to thank you guys for participating in this session with me. I'm Dr. Patricia Etheridge from Phoenix, Arizona. I am adjunct faculty at Grand Canyon University in the doctoral nursing program. And as Portia shared, I spent the bulk of my career in nursing and pharmaceuticals. On my primary focus on access for the underserved in the community. I am the proud grandmother of 2 little baby girls. With that being said, I will start with our the presentation. And the agenda, what we're going to talk about, and it may seem a little basic at times, but I wanted to refresh us on the definition of telehealth, advancing health equity for women, telehealth services today. I wanted to present or give you an overview of the evidence, the effectiveness of telehealth, talk a little bit about barriers and future considerations for telehealth in your community. Next slide. And I will. The World Health Organization, WHO, defines telehealth as the provision of healthcare services by healthcare professionals utilizing technology to exchange information in diagnosis, treatment, and prevention of disease. In the broadest definition, and we used to call it telemedicine, and people still do, it can include basic communication like telephone calls, text messages, emails, online patient health portal, faxes, allowing patients to schedule their own appointments, view their lab results, appointment summaries, communicate with their providers. And with the addition, we have apps for telehealth, we have WhatsApp, we have social media, Facebook, Twitter, a lot of software, Zoom like we're on today, MS Teams, and you have home remote monitoring devices, reactive and proactive. And you have a combination of all of these. So a lot of modules or a lot of modalities come in under telehealth definition. Many healthcare organizations today and payers, they look at 3 specific telemedicine modalities that they focus on. They are video conferencing, where you have a real-time exchange of information and video with the patient or another provider. They store and forward information, where you see an online consultation in which the patient information is sent remotely to a clinician to review and send back diagnostics and treatment recommendations. And then we also have remote patient monitoring, where patients actually, hook up themselves to a device at home, either a pain management device, a blood pressure device, an EKG, and send that data, real-time data, to their clinician for review. So overall, there's a lot encompassed into what telehealth looks like. So everybody has a different definition for the pieces that they use. Next slide. I pulled this slide from the Kaiser Family Foundation, and it's well documented out in the literature from Kaiser. And just to show you that telemedicine can facilitate a broad range of interactions using different devices and modalities. And what they look at for interactions, you have patient to provider, but a lot of provider to provider occur during telehealth communications. And the reason I wanted to show you this slide is most particularly that this can occur at a patient's home, at a clinic, or a hospital. And a lot of times I've been on Zoom calls with providers that were like in the next office to me for convenience. But anyhow, and a lot of devices are being used, a smartphone, a computer, and a laptop, a tablet, and a monitoring service devices. And the reason I put this in here is that I wanted to share with you a little bit. In 2013, I took a trip to Thailand. Gee, I forgot for a moment. To Thailand, just because I wanted to have an opportunity to understand the Kayan tribe and also the Hmong tribe, also in northern Thailand. And the reason mostly I was doing some work with the Hmong refugees in California, just around the Los Angeles area. But anyhow, when I got there in 2013, I was so surprised to see that in the Hmong tribe, you wouldn't believe how many people, especially the business owners, who were using an iPhone. I wasn't expecting that. And also when I went up to see the Kayan tribe, and these are the long neck tribe people, they were using iPads. I was totally surprised, unexpected. So technology is everywhere. Granted, as we'll talk about as we move forward with barriers, they may not have the best access or internet access. However, especially in the urban areas of underdeveloped countries, you will see that that these devices are available there. Next slide. So let's just talk about a little bit more about defining telehealth. It is used to, let me get caught up with my slides, I apologize. It is used to define services that may include information and telecommunication technologies and healthcare delivery for a specific patient involving a clinician across distance or time using remote real-time clinical visits and remote monitoring. And as most of you may be aware, already aware, interactions can occur asynchronous or synchronous over distance, telephone conversations, emails, text messages, and allow that interaction between the patient and the healthcare provider, and could replace or supplement an in-person visit. For the purpose of this presentation, I want to focus on that we're talking about interventions that are used technology to facilitate interactions at a distance with specific patients and clinicians, bi-directional and definitely linked to clinical care. So I'm talking about a patient and a healthcare provider interaction for most of this presentation. So not including texting and telephone appointment reminders and collecting data. All of that stuff does occur under telehealth, but for the purpose of this, I want to focus on the communication and the assessment between a provider and a patient. Next slide. Advancing health equity for women. The CDC, the U.S. Center for Disease Control and Prevention, describes health equity as achieved when a person has the opportunity to attain his or her full potential, and no one is disadvantaged from achieving this potential because of their social position or socially determined circumstances. Healthcare inequalities are reflected in different length and quality of life, rates and severity of disease, disability, and death, and access to treatment. And as you know, these differences have resulted in poor patient outcome, and they continue to result in that. Next slide. The coronavirus epidemic has led to the rapid adoption of telehealth as a strategy to improve health services while reducing the risk of coronavirus exposure. The pandemic has also highlighted existing disparities and placed a spotlight on the concerning rise of the incidence of interpersonal violence against women and girls as a direct result of COVID, the mitigation measures of them having to stay at home mandates, and that is well documented in the literature. Telehealth, next slide. Telehealth can help advance health equity for women who adversely are affected by these disparities due to socioeconomic disadvantage, racial and ethnic minority status, and rural locations. Now, next slide. I apologize, I'm a little out of sync because I'm using my computer, paper, and my iPhone because I couldn't get my Zoom to work, so I apologize in advance. Most of you are probably aware also of the three central domains of health equity framework. These are availability, accessibility, and acceptability. And I put a little bit in here for you on the coronavirus aid relief and economic security, which is the CARES Act in the US, provided federal funding to increase telehealth access and provided the infrastructure to increase capabilities and services for women, most importantly, including provisions of family planning. And then Title X, which is another service grant that we have in the US, have added to enhance and expand telehealth services for comprehensive family planning and related preventative health services. The Federal Health Commission, and these are the people that follow access to the internet in almost all of the world. They report that, or in America, I should say, 90% of Americans in the urban areas have access to high-speed fixed services. However, that decreases, as you know, in the rural areas down to 65%. And then if you're on a tribal land, 60% it decreases. Nearly 30 million people, Americans, do not have access to good internet. And we all, even to today, know what that feels like for our internet to be patchy. According to the International Communications Union report, in the developing world, the internet penetration is 87%. However, in developing countries, 47%, and then in the least developed countries, down as low as 19%. So something, even though we wanted to really focus on telehealth, this is, access to the internet and being able to communicate, and for that provider and the patient to be on a virtual meeting, you have to have an internet that works or that have access to that to internet. Under accessibility, there's been many studies have shown that women, particularly low income women, delay or avoid necessary health care due to transportation or childcare. And also to increase telehealth, one can appeal to, we have to ensure that we're appealing to culturally and linguistically diverse patients, and telehealth can do that. They can help patients by accessing their physician, increase adherence and satisfaction. And under acceptability, numerous studies have shown high satisfaction among patients and clinicians for telehealth interventions. In a most recent survey, 76% of consumers said that they would use telehealth services going forward. 67% of providers view telehealth positively. And just notice that data came from 2020, and now we're into 2022, where we've had another year and a half experience on using telehealth. Next slide. So here I'm going to roll through some of the evidence that's in the literature on the effectiveness of telehealth. Telehealth can help with screening, diagnosis, and treatment. It can bridge gaps for women, especially in the rural area, and broadening outreach efforts to the underserved. Allows patients to access their services from their home. Allows a clinician across distance and time, like we said earlier. It improves access using remote real-time clinical visits and remote monitoring. And this is so important for the patient to have direct contact with their provider. And then at the same time, decreasing the transmission of infectious agents from person to person. It can increase compliance with office visits. This has all been vetted out in the literature. It had lessened stress when patients have a limited transportation. It can increase access to specialists, especially in areas that have sparse healthcare providers or specialists, and clearly can help address childcare barriers. It also allows women to stay with their same provider within their same existing healthcare system. And it also allows them to meet with new providers when they don't have the ability to be in person. And it also can serve as an adjunct to our current care model. So we're not going to say, let's go to 100% telehealth, but it can certainly adjunct after initial visits. And we'll see that as we go through. And it's definitely been found in the literature. Studies have also shown that telehealth, next slide, that telehealth can provide routine or non-emergency care when the healthcare services do not require that direct patient to patient or provider interaction, such as, and what we mentioned earlier, Dr. Lowell did about psychological services, so counseling, education. It can also provide a chronic disease management, especially oncology and chronic care, especially for elderly in nursing homes or that cannot get in to see a provider. You can do some routine care, some follow-up care, especially screening. It also addresses unmet reproductive health needs, such as family planning, contraceptives, treatment for STIs, safety education for women who've been affected by violence. And those studies have been shown effective, that doing this via telehealth, you get the information to the patient and they've been able to use it. But like I said, particularly in rural areas and patients with childcare barriers. It also increases access and availability to geographically isolated, the underserved population. So that has been well vetted in the literature over and over. So I put this here. I also put two examples that I wanted to bring to your attention of two important studies. They were one done by Turner and their researchers in 2022, and it was for oncology patients, and they focused on telehealth, and they said telehealth was good in establishing and maintaining that patient-provider relationship, especially during oncology treatments and follow-up and side effects. And also, which I thought was so important, I want to share with you, the coordinating of care with the healthcare provider and the informal caregiver. So including the family members in that virtual visit, and just something that, when a patient often goes in for an inpatient visit, may or may not bring their caregivers into the room to talk to the provider. So being able to do that virtually, I thought was a fantastic study that was done, and they showed that that was very significant in their patients. Also, another important study I wanted to pull out was that ACRS in 2021 had reported that patients had similar outcomes virtually via telehealth compared to their inpatient care, especially for diagnosis, treatment, and clinical outcomes. So as recent as ACRS, they were able to show that telehealth works and patients are receptive to it. And I think this is something really important for us to know, that patients are receptive to it and it works. I will hit a few of the barriers, next slide, that are definite barriers. And these are especially in establishing relationships for a new patient. And I experienced that myself during COVID, when I had to meet with a new primary care provider virtually, who I'd never met before and did not know anything about my history. So that is difficult for new patients and even for us as healthcare providers when the initial visits are not in person. However, research has shown that if that initial visit is in person, then any subsequent visits that the patients have done showed a perceived ease of use, its benefits and intentions. So it's just something to think about when you are recommending or encouraging telehealth. You may want to say, if it's possible for that patient to come in for that initial visit, might be good for them to know the provider. They said another barrier is patients and family, and this is one that's not going to be a surprise to anyone, lack knowledge on the use of technology, or there's health literacy concerns. And that's something that we, especially on this, in this group of participants, we are all aware of that, and it's keenly at the top of us whenever we go to do anything for patients is that health literacy piece. Telehealth interventions could widen disparities because, there's a chance that they may push it out totally. And then when you have patients that don't have internet access, digital literacy, confidentiality concerns, and equity concerns, all, especially age and language barriers, they will become a barrier, a significant barrier as we go forward if we don't address them, but roll out telehealth as the be all end all to how we care for patients in the future. Connectivity and communication were major issues with insufficient bandwidth and interrupted transmission. And we've all been subject to that. So we can imagine what that would be like if you were trying to communicate with your provider with a sick child, or you're sick yourself with a temperature, those kind of things, and then having problems with the internet. And then the other thing that came up in the literature that I thought was significant to share, that a lot of people use interpreters, and they noted during telehealth that it was difficulty accessing an interpreter or maintaining that interpreter services when technology difficulty, when you have problems with the internet occurred, and then what happened, then they had to delay the visit and reschedule. So just something to consider. I didn't hear you. And other future consideration, uncertainty remains one of the most that telehealth is one of the most effective approaches for delivering telehealth. However, there's uncertainty about it. And how do we best mobilize the telehealth services to address the healthcare needs, particularly those when it comes to equity in women? There's a lot of research out there, but I do believe that sometimes you got to still try it to see if it's going to work. And we need to engage those women to let us know what works for the patient. As always, we got to continue and be concerned about the needs for improvement in culturally and linguistically appropriate services and materials. Future research for telehealth interventions should evaluate the effectiveness of telehealth on preventative health interventions and strategies, especially making sure that we include the disadvantaged women in those studies, and looking at rural locations, their socioeconomic factors, and race and ethnicity and gender identity. All going forward, any study's got to include that patient population who is so important for us to reach. And then we also need to look at longer term outcomes and trials on the rigorous of the any harms that may happen with using telehealth, and the benefits according to the different demographic characteristics and clinical factors, patient preferences. Next slide. And another thing to start to consider, as telehealth, we've had an explosion of telehealth. So making sure that we include protocols and using in-clinic visits when we can for new patients and maintaining the same provider strategies. I thought that was an excellent study. And questions remain around also whether these services can and should continue to occur post the pan-epidemic. And then, given patient perceptions, preferences, patient choices and barriers, a lot of things, especially patient perceptions, we've not assessed. One of the things I noticed that there was a very scarce in the literature. I don't think I've seen anything that came across my desk when I did my review of patient engagement, engaging patients on these strategies. We had that study saying that 67% patients were favorable for it, but really digging into that. And then going forward, care models should be developed to include shared decision-making to elicit patients' preferences, improve efficacy, satisfaction to help reduce health disparities. Next slide. And in summary, as we all, everyone on this call, we talk about social determinants of health every day, but they should not only be considered on a macro level. I believe, and as does I'm assuming everybody on the call, that on a local level to truly address the healthcare needs within our community. Updating our approach to women's preventative services and reproductive health to include telehealth for remote counseling and monitoring can decrease the gap as seen in the literature on disparities. And then, changes in regulatory and payment policies that have supported the increase during the pandemic. Going back and look at that data may inform us on patient and clinician preferences. Literature has shown that telehealth is accepted by patients and it's similar to in-person visits. I thought that information is so important for us. And then I wanted this review to serve as a resource for policymakers, practice leaders, and other stakeholders to inform future efforts to evaluate outcomes for women presenting for preventative services and populations that are adversely affected by disparities due to socioeconomic disadvantages, race, rural location, which is important, which is very important regarding the use of telehealth. And with that being said, I'm happy to take any questions or however Portia wants to deal with this. Thank you.
Thank you so much, Dr. Etheridge. We really appreciate everything that you've given us right now. If there are questions, please make sure that you put them in the chat. I did not see any specific questions other than thank you, this is good information. You can use the Q&A or the chat feature to ask your questions. And if you need time to think about your questions, that's fine. Please take that time to think about your question and just make sure that you indicate who the question is for when you do put it in the chat so that we can get it to the appropriate speaker. And while we're changing speakers, we are interested in knowing about your telehealth experiences. So if you've had a telehealth experience as the consumer, as the patient, we invite for you to write that in the chat and tell us about your experience. Tell us about that encounter, what worked, what went well, and what are some things that you feel like will make it better? What are some things that we could change as healthcare practitioners for you as a consumer to buy into telehealth more? And while you all are doing that, I'm going to introduce our next speaker, which is Victor Okai. And I'm going to read a little bit about his bio, and then the next voice you hear is going to be Mr. Okai. He is a producer, script writer, cinematographer, director, and film consultant. He is one of the founders of the Directors Guild of Nigeria, a script writer with the New Village Headmaster. He's done a lot of good work I see on his bio. He has filmed several features for the BBC World Service News and the series African Dreams, Africa on the Move, and Eco Africa. Victor holds a BA in Mass Communication and an MSc in Public Relations from the University of Nigeria, Lusaka. He also holds a professional certificate in films, TV production from the University of California, Los Angeles, and he's attended various courses in film production at NAFTI in Ghana, also in CFAB in France, and he also spent some time in Germany, amongst other things that he's done. He is currently rounding a doctorate in business administration, DBA, with the University of Nigeria. He is currently the director of the International Film and Broadcast Academy, Lagos, and formerly the director of studies at the ITPAN Training School in Lagos. Victor has been an external lecturer with the National Film Institute in Jos for over 10 years and was the consultant for the formation of the PEFTI Film Institute, also in Lagos, and designed its curriculum. So please help me in welcoming Mr. Okai. We appreciate your expertise in this hour, and I'm going to put myself on mute.
Thank you very much. I think I'll have to share my, what do you call it now? My screen. So just excuse me and let me just pick that. That would be it. So thank you, everyone. You know, after Dr. Etheridge spoke, I felt like there was nothing more for me to say. That's the disadvantage of speaking after. You know, that was a very beautiful paper, by the way. Thank you very much. I'll be talking about advancing health equity using digital health. The World Health Organization considers health a human right. According to it, health equity is achieved when everyone can attain their full potential for health and well-being. Health and health equity are determined by the conditions in which people are born, grow, live, work, play, and age, as well as biological determinants. Equity, on the other hand, is the absence of unfair, unavoidable, and remediable differences among groups of people, whether these groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality, e.g. sex, gender, ethnicity, disability, or sexual orientation. I'm still quoting the World Health Organization. Now, the Centers for Disease Control and Prevention says the health equity is achieved when every person has the opportunity full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Now, it's easy for politicians to chant health for all. I mean, in your mind, I'm sure you added the year 2000 or universal health coverage. But the reality on ground is different. Even in the most advanced countries of the world, in spite of advanced medical breakthroughs and healthcare systems, people still lack access to basic health facilities. According to a study from the World Health Organization, the World Bank, more than half of the population lacks access to basic healthcare services, world's population that is. And of this number, almost 100 million are pushed into extreme poverty. Why? Because of health expenses. Now, several factors are responsible for some of these disparities or disadvantages. According to healthpeople.gov, race or ethnicity, sex, sexual identity, age, disability, socioeconomic status, and geographic location all contribute to an individual's ability to achieve good health. I'm sure some of you may be familiar with this picture here. What you see here is what is usually touted most of the time when politicians or those in authority say they're providing health. They talk about equality. And I'm going to give an example as I go down. What you see in the first part of the picture here is a situation where they say there's health for all. But how, when providing health for all, how accessible really is it for everyone? I'll come back to the issue of equity. I just want to demonstrate something here. In the West and wealthier countries where there are advancements in health, for instance, illegal immigrants cannot enjoy health insurance or free access to health as a result of their status. You know that a lot of them would rather suffer in silence because if they show up, then obviously they'll be on the next plane or ship back to their countries. You know, so where we talk about equality, yes, there's health, but this man here may well represent that immigrant. This health may be there for everyone, but can he really access it? And so according to, so consequently, you find a situation where they're so near and yet so far away from access to health. According to WHO, health and health equity are determined by the conditions in which people are born, grow, live, work, play, and age, as well as biological determinants. Structural determinants like political, legal, and economic, with social norms and institutional processes, shape the distribution of power and resources determined by the conditions in which people are born, in which they grow, they live, they work, they play, and age. People's living conditions are often made worse by discrimination, stereotyping, and when I'm talking about okay, of course, when you talk to people like LGBT persons, and stereotyping as well, and prejudice based on sex, gender, age, race, ethnicity, or disability, among other factors. Let me talk, for instance, about, the bigger health facilities in Nigeria, for instance, where I'm coming from, where I'm speaking from right now, you'll find that, yes, there's provision for like people with disability to be able to access these facilities. But in the private clinics, which are even closer to the people and which you find more readily accessible in the rural areas, you find that people like that, they get to places like that, I'm getting access even to that place where you want to access health, treatment and all that, even becomes another struggle by itself. But fortunately, in recent times in Nigeria, for instance, the government has put up a disabilities act right now that will ensure that in the coming years, all facilities, public facilities especially, where there'll be access for all persons, whether you are a person with disability or you are an able person, you are somebody who is not living with any disability, for instance. Discriminatory practices are often embedded in institutional and system processes, leading to groups being underrepresented in decision-making at all levels or underserved. You find that in heterogeneous communities and societies like Nigeria, where we have over 300 ethnic groups. But when you talk about Nigeria, you talk about three major ethnic groups. You talk about the Yorubas, the Igbos, and the Hausas. And so in terms of representation, the minorities, they may have more numbers in terms of number of ethnic groups, but they are overwhelmed by the majority, three tribes, for instance. So in terms of representation, because we do representational democracy like you have in the US, we have the House of Reps and Senate, and so you are represented by population, by state, but more in the House of Reps, for instance, is by population. And so if your population is very small, then you're underrepresented, which means therefore that if you're looking for access, whether for healthcare or whatever, your voice is that of a minority. And so it kind of limits how much you're able to get, because obviously the majority will have, you may have your say as a minority, but the majority in most cases would have their say. I'm just giving examples here of how some of these things can hinder access, or if you like, equity in healthcare. Now, so even representation and decision making and being underserved could be a hindrance as well. Now, progressively realizing the right to health means systematically identifying and eliminating inequalities resulting from differences in health, and overall living conditions. Sorry, I'm having a challenge scrolling. Okay, thank you. So we may tout equality, but we know that equality there's no equity in equality. Access is elevating the minorities and the underserved to a position where they can also have access. But is that really enough? I think the ideal situation would be to bring down all barriers, to access to health, so that everyone can have unfettered access, and in a uniform way, which is basically, when we talk about inclusion, making sure that all parties are equally represented, there is no discrimination of any sort, and everyone can have access, which is, the ideal. This is a dream. This is where we're hoping that we'll get to. But how do we achieve inclusion, liberation, and true equity? This is where digital health comes in. Now, Dr. Etheridge has, I hope I got the name right, done a lot of justice to it. So I may just be repeating some of what she has said there. But according to the US Food and Drugs Administration, digital health includes categories such as mobile health, health information technology, wearable devices, telehealth and telemedicine, and personalized medicine. Technology has revolutionized and disrupted the traditional way things have always been done. Today, without owning a single car, Uber controls and provides jobs for millions of cars and their owners. The same can be said about Airbnb, who do not own a single hotel room, but provide access to millions of rooms around the globe. When the COVID pandemic struck, remote working, something that die-hard HR persons for whom clocking was the next best thing since sliced bread, came to terms with a new reality. Zoom, the app, suddenly narrowed the space between people and opened up a new space for conferencing, meetings, and collaborations across millions of miles, thus saving a lot in terms of costs, and if you like, emissions as well in the environment for unnecessary, I would say, unnecessary commuting. Is there a lesson for the health sector here? I want to share a case here. In Abia State, Nigeria, the state government has introduced, and for now, as far as I know, that's the only state that has been able to do that very effectively, has made it a major policy item. You know, it has introduced telehealth services for people in rural areas to access doctors through nurses on ground who they guide through the phone in diagnosing and treatment. And when I say phone here, that includes everything that goes in the phone, whether you're talking about WhatsApp, video, and all of that, you know, in diagnosing and treatment of patients. Simple as this may seem, it is creating access to health that bad roads, costs of transportation, and heavy medical bills would have impeded otherwise. So just an example here of, you know, telehealth and how easy access can be from a remote location, you know, how people in remote locations can have access to expert healthcare. Wearables today, and when I'm talking about wearables, I'm talking about something like what I'm putting on here, are so sophisticated they can measure blood pressure, heart rate, calories used or burnt, oximeters, incidentally, I don't know how they do it, but you know, some of them contain this as well, oxygen levels and more. What this means, therefore, is that as they become cheaper and more available, more people can monitor their health and self-manage it, thus freeing up more space in hospitals as a result of emergencies. I mean, not everyone may have access to a SFIG, for instance, or, you know, in a hospital and all that. But if you have it, I mean, you may not be able to carry it. Of course, there are wearable, small portable SFIGs, but, you know, it's not something you want to wear around. But, you know, having these wearables mean that there are so many things that you can monitor at once, you know, in your health. And if things are getting to critical points, as they get more sophisticated, of course, then you know to quickly attend to it. You know, for me, for instance, sometimes if you live a sedentary life, or you have sat down for so long, what the wearable does is sometimes some of them, they remind you through a beep or so that you have sat down for too long. It's time to stretch and move your body. So what that does, it helps you, you know, exercise some more. And for some of us, we give ourselves daily targets of, let's say, 10 to 15,000 steps a day. So this helps, you know, basically in improving healthcare and exercise. Not everyone may have time to go to a gym, but you know that with that, you know, on your wrist, you're motivated to exercise, to walk some more, and you know, and so it does quite a lot. So this is, you know, you find that wearables are helping us in our health, much more than before, And like I said, more people can monitor their health and self-manage it, thus freeing up more space in hospitals as a result of emergencies. These are examples of wearables here. Now, I visited a tertiary health facility in Lagos for a routine checkup and waited for quite a long time before they could trace my card. True story. Upon further inquiry, I was told that the shelves containing the medical records had collapsed. And so I saw for myself. Unfortunately, with the phone I recorded it with crashed, I had to, format it again. So I lost the pictures there, and I've been so busy. I wanted to visit there again and take the picture. I would really have liked to show it here because it still has not been fixed. I promised I was going to help them fix it, but I've not been able to do that yet. Now, all the medical records are just heaped, and I was shocked. Upon further inquiry, I saw that the shelves containing the medical records had collapsed, and so cards were listed all over the floor. As simple as the solution may appear to those of you in the West, which is simply, why not digitize the process? Challenges in this part of the world include things like power, bureaucratic bottlenecks. I heard a sound, I'll soon be rounding up. I don't know if that's a sign that I should round up, but I'll soon be doing that, I promise you. Power, which you take for granted, bureaucratic bottlenecks in getting approval for something as basic as not even acquiring computers, but even fixing those shelves that were broken down, that collapsed, and acquiring computers and digitizing patients' records. This negligence can be the difference between life and death in an emergency. Therefore, digitizing health records for easy access to patients' history, especially in the third world, could significantly improve health services. It's basic, but it could make a world of difference. Telemedicine is basically a tool that makes healthcare more accessible, cost-effective, and increases patient engagement. Patients in remote and rural areas have increased access to a physician who can reach them virtually. Now, as you can see here, the physician can actually look at the patient and, and see what is really wrong and advise on what steps they can take next. Patients and doctors can communicate in real time on the same computer screen. Additionally, they have the ability to view and record data from medical devices located in remote locations. Patients no longer have to wait for an appointment to see a doctor. Because of the advances in telemedicine, patients can now speak with a doctor from the comfort of their homes. Many medical missions can be achieved effectively through these means. I know, for instance, there was a conversation not very long ago, and I was told about an aborted medical mission to Nigeria because of security challenges. Apart from the physical things that are taken, there are a lot of things that can be done even remotely by experts. I know many Africans in the diaspora, for instance, want to give their services free of charge to people in Africa and to rural places and remote places where people don't have access to expert care. I believe that telemedicine can bridge this gap. Although there are challenges like access to internet, power, and some of the technology required, the cost for me and my new school compared to the benefits that are derived. As we advance in the use and application of artificial intelligence, apps are gradually becoming as sophisticated as humans in diagnostics and treatment of ailments. As vehicles become more electronic, machines have replaced humans in the diagnosis of faults. And you can see that today, even mechanics can no longer function without them. When you take your vehicle, the first thing they say to you is scan. That's doing what the doctor would traditionally do, or the medical, how do I put it, the people in diagnosis, So, but these machines are replacing mechanics for your auto, and so you find that even the mechanics can no longer function without them. The same is gradually becoming true in medicine, and smart doctors and hospitals should take advantage of this and begin to develop apps that can do the job. I would advise, do not be afraid. There will still be work for you. It only makes your job easier and faster. What it will do is ensure that only emergencies come to hospitals. Recent breakthroughs in clinical and biomedical engineering have made clinical investigations and early detection of diseases faster and easier. Digital health is the fastest way to scale healthcare, to reach so many more people, at minimal cost, to create access and equity in a world of inequality, and inequity. If governments and indeed the WHO is sincere in delivering health as a human right, then all persons, irrespective of age, gender, class, geographical location, or physical challenges, should be able to access healthcare. This is my dream, and this is my desire. Thank you very much.
Thank you so much, Mr. Okai. I appreciate everything that you have shared with us. We do have a few comments in the chat, and we had one question. So what I would like to do, I'm going to pose the question to our speakers, and I want you to think about this, because this is asking for a resource. And at the end of this, we're going to be able to helpfully provide this person with a resource. So here's the question that I would like for you to think on, all of our panelists. What courses can we young ones that are interested in telehealth study to promote and partner with organizations that promote telehealth? So this is for a young person. They are interested in working and partnering with organizations that promote telehealth. So what kind of courses or resources, webinars, programs can they attend in order to do that? So that's the question on the table. So please, speakers, think about that, and we will come back to that towards the end. I have the pleasure of introducing our next speaker. It is Miss Jacqueline Williams. She is a board certified registered nurse from Los Angeles, California in the United States. She has 21 years of nursing experience with specialties in women's health, education, global health, and forensic nursing. Thank you, Jackie, for working with that population. Jacqueline is the founder of Global Women's Health Promotion, which is a 501c3 nonprofit currently working on menstrual hygiene and sexually transmitted infection prevention initiatives. She is also the CEO of Aspire Nursing Consultants. She is committed to giving back to the local and global community through patient education and service. So please join me in welcoming Jackie. And I am going to actually share her slides for her. And let me get my screen.
Okay, thank you, Portia, for that introduction. To be with you all today to actually talk about telehealth as it relates to women's health. So why do we look at telehealth? Well, first of all, let's look at the health disparities that are present in the world today. Health disparities cause a lasting effect when left unaddressed. The lack of adherence to care leads to a cycle of illness, which impacts a woman's health as well as the health of her family. While actual barriers may be different in various parts of the world, there is a common thread in the challenges and plight of global women's health. Many women place the care and health of their children and families before addressing their own health issues. And this fact must be addressed because the health of the community starts and depends upon the health of the woman and the girl child who will eventually become a woman. Barriers may be present to prevent women from being physically present in an office to receive essential care, or it may cause a delay in healthcare for that woman. Geographical locations may be an issue due to limited medical services and clinicians in an area, and also lack of transportation to access those services from remote communities. Oftentimes, if a woman is able to receive initial in-person care, she may not be able to receive much needed follow-up care. And As the other speakers have said, we have seen an increase in the use of telehealth in recent years. With the onset of the pandemic, it has shown us how telehealth can be used to connect patients to clinicians in times when in-person visits may not be practical or may not be possible. Next slide, please. Telehealth has a great role in improving the lives of women and girls around the world. The access of service can provide an impact on those communities without immediate access or lack of time to obtain services. Many health services do not require a physical examination. It only requires a face-to-face visit with the clinician, which can be done through telehealth. Telehealth visits can be used to obtain medical history, anxiety and depression screen, follow-up visits, review of test result, and also address patient questions concerning medication and disease management, as we've previously heard. Next slide, please. There are various telehealth providers specializing in women's health services, attempting to bridge the gap in access to services for women. Remote lab testing is gaining popularity, where patients can perform lab tests at home, such as glucose monitoring or sexually transmitted disease testing, such as for chlamydia, gonorrhea, or HIV. And this can be done with or without the virtual presence of a medical provider while the test is being done. Also, pre and post reproductive telehealth visits may provide much needed medical follow-up for women where these issues may otherwise go unaddressed if they cannot obtain the services in person with the physician. Next slide, please. Health counseling is key to empowering women to take control of their health, not only for themselves, but also for their communities. Because we know that if you teach a woman, she will most definitely share that information as she cares for others. There are providers, nurses, nonprofits, NGOs who offer women health education services to those women who may not otherwise have access not only to healthcare information, but accurate healthcare information that's coming directly from a medical provider. Education for birth control, cancer prevention, menstrual issues, and menopausal symptoms are just some of the services that are offered as health education services to women. Most importantly, women can be directed to local support and services, which is so important because sometimes women may not know what is available directly around them in order to receive these services. Next slide. So the future of telehealth is bright for women's health. There is a need to increase systems to be sustainable, accessible, and cost-effective for women. We know that smartphones are more readily available in rural communities, but there's also really a need for increased computer literacy and also access to reliable and affordable internet services, whether that's in a person's home or whether that's in a central internet cafe that they may be able to go to get these services. Provider coverage and reimbursement also needs to be addressed. And we also need to look at regulations that should be put in place to protect telehealth platforms, as well as the privacy of medical information. Next slide. So to wrap up, there is definitely a shift in healthcare delivery towards telehealth. And this is most definitely a positive shift because, again, it allows for women who may not actually have immediate access to these services to get these services at, an easier way for them to get the services. And I'm speaking of women, whether they're in urban areas or also in rural communities, especially in developing countries. We know that delay in essential care, again, will cause long-term health care issues for women, but women are less likely to delay this much needed care if they have telehealth accessibility. Telehealth can solve the issue of geographical and other identified barriers, including eliminating transportation expense and time. And we need, again, to look at ways of improving telehealth limitation and communication infrastructure. Telehealth plays an important role in the identification of health issues and the reduction of healthcare disparities. It can provide a peace of mind for women and give women one less thing to worry about, which we know as women, we have a lot of things to worry about. Our health should be just one less thing that we have to worry about, especially how are we going to get the information or those services that we so desperately need. Lastly, the health of the family and community is dependent upon a healthy woman. We must protect the health of women, and telehealth is an excellent pathway to achieve that goal. Thank you.
Thank you, Marshall Jackie. I appreciate your presentation so much. As we get ready to transition to the next speaker, which is going to be, excuse me, that's going to be Engineer Kuni Adesida. I didn't know if you wanted me to share your slides or if you had your slides that you wanted to share. But as we get ready to transition, if you have your slides, you can go ahead and start to share screen and get yourself set up. There is a question in the Q&A that I want all of our panelists to think about. And if you can answer this in the chat, great. If not, we can hold it to the end. The question is, with equity and equality in mind, what is the best way to provide technology to people in underserved areas? And I think that this is very important and is timely because there was a lot of chatter in the chat box talking about the inability to provide telehealth in certain parts of the country in Africa and certain part of the continent of Africa because of connectivity issues. So I really want us to think about, what does that look like for our rural places and for our lower income countries or countries that do not have the infrastructure to sustain broadband and to sustain Wi-Fi and to sustain access to the things that we need in order to provide telehealth. I also want to make an appeal to the healthcare providers who are PhD prepared, who are doctorate level scholars. We need more research in these areas. I went to a UN site event for Sigma this morning, and they were talking about how do we get more nurses and more nurse midwives available for research in low to middle income countries, so that we can really hear the voice of the people and see it from the perspective of nursing. Because for nurses, what we do is we look at that human experience and we try to figure out ways to make that better for individuals. So I will call on our healthcare allies and our friends to say, we need more research to talk about what these interventions are. And I see you doing, what are you doing over there, Toya? What are you doing? What is happening back there? You're on mute. You're on mute.
Oh, no, go ahead. I will say that after. It's just one thing that we are working on right now, how to get, even upgrade the community healthcare workers that we already have, especially in places like Africa and Nigeria, because we are now using a lot of community healthcare workers to help with telehealth. Mm-hmm. And talking about the broadband, what we also do, for our women in the rural areas is we empower them to have solar, and we actually send some of these women to India to be trained on solar panels, so that when they come back to the community, they are able to apart from getting economical benefit of it, they are also helping the community with the electricity, the light, and also the source of information that they need to go ahead with telehealth. So that's a point that we are working on. And thank you for mentioning that.
Of course. And I think that one of the things that we have to be very aware of is this idea of intersectionality. So when we're talking about health inequities and we're talking about that space where people are being influenced by so many different issues, like how they present and their social determinants of health. We have to understand that when we're delivering interventions and we're talking about resources and steps, we have to look at that across a spectrum. We have to look at it across different levels and different domains. I would invite you to look at the National Institute of Health on minority and minority health and health disparities, their research framework. And it really takes a look at health disparities across a socio-ecological perspective. And it looks at that intersectionality of it. So we can't just say, here's a smartphone if the infrastructure doesn't support the use of the smartphone. Or, you know, if we want to do telehealth in certain areas, but the infrastructure is not there. And there's a lot of other social determinants of health that will impact the ability to have that to be efficient. So our next speaker is going to be engineer Kuni Adisida. Please forgive me, Kunle, if I mispronounce your name. He is an IT professional with focus on digital health solutions with 2 decades of experience developing and deploying electronic health solutions for better healthcare delivery. He specializes in administrative technology and progressive systems, as well as applications geared towards standardization with perfect patient flow experience and effectiveness. He delivered the award-winning Cranium Complete Health Information Management System and has the patent. We definitely need to know more about that when you speak. He has special skills in digital health, software development, MIS, web and mobile application, and also in leadership roles. His hobbies are traveling and driving. So I'm going to share your presentation and I'm going to put myself on mute. You have 10 minutes and you can start whenever you would like.
Unfortunately, I just want to add that it's also a life marshal, Engineer Kunle, and also Mr. Izzy Esozo. Thank you.
Okay, thank you so much, Pasha. Thank you, Dr. Tony, panelists. I want to appreciate everybody. I will go straight into my presentation so that I don't waste much time. So, implementation of telehealth to improve women's health and well-being. Yes, we've been talking about that. I'll just take the background. Globally, hypertensive disorders of pregnancy, which is HDP, particularly preeclampsia and eclampsia, are the leading causes of maternal and neonatal mortality and impose substantial burdens on the families of pregnant women, their communities, and healthcare systems at large. Next slide, please. Thank you. Preeclampsia occurs when the pregnant woman has concurrent hypertension and significant proteinuria. In the absence of early identification and timely case management of preeclampsia, the trajectory can put women at high risk of life-threatening complications. Each year, it is estimated that hypertensive disorders of pregnancy, which is HDP, complicates 10 million pregnancies, resulting in 76,000 maternal and 500,000 fetal newborn deaths. Nearly all these deaths, which is greater than 99%, occur in low and medium income countries, particularly in South Asia, and Sub-Saharan Africa. Next slide, please. Previously, the definitive management of hypertensive disorders of pregnancy has focused on health facilities, level interventions with antihypertensive and anticonvulsant therapies, as well as timed delivery to reduce risk. However, thousands of women in hard-to-reach areas, due to resource constraint, continue to suffer severe disability or lose their lives because of delays in early identification, triage, transport, and clinical processes that could feasibly be managed within a woman's own community at levels of primary healthcare centers or nearby via admission or a more central referral hospital. Next slide, please. Okay, so I look at a typical case study. A few years ago, there was a study by University of British Columbia, which was sponsored by Bill Gates Foundation. It's a community level intervention project for preeclampsia and eclampsia, which is CLIP, in South Asian and African countries. It was carried out somewhere in Ogun State, and I was actively involved as the ICT consultant. Now, the focus was to identify from available capture data, evaluate by eligibility, and intervene by referring to a government hospital for immediate attention on suspected cases of preeclampsia and eclampsia in pregnant women between the age of 15 to 49. Next slide, please. Thank you. How did complete health information management system help? We had a complete health information management system deployed on a web server at the chosen research center in Ogun State, which directly had strict data security systems in place with high-end alternative data and power backups. A remote access was also granted directly to Vancouver, where data analysis was being done automatically with the use of artificial intelligence. I'll speak more on that. Now, the artificial intelligence support systems to clinicians was used to identify suspected cases based on symptoms and data gathered from women in the local community directly via handheld devices we configured for food data entry team. Now, I've heard many speakers today. I appreciate what we've been saying. It's good enough. But at this point, we are core on the field, and we need to know that achieving electronic health, be it EMR, EHR, or telehealth, is actually possible anywhere. The major issues that could arise and could confront any organization trying to make this work, usually internet deficiencies, power-related issues. Yes, we have backup issues with data, loss of data, acceptability from the user end, user friendliness of whatever app they are using, and then ensure that these things are well deployed in such a way that hackers cannot get into the system. Plus, of course, what is major in ensuring that these things work is to ensure that the stakeholders are on top of it. I'll give us some scenarios even as I go on. Yes, next slide, please. Okay, so how does this improve women's health? With my over 2 decades of professional experience in digital health, I can boldly say that the use of technology to capture, analyze, and suggest presumptive diagnosis as well as best plan of care as a form of clinical decision support to clinicians is capable of going a long way to address and reduce the rate of maternal death in pregnant women across the entire universe. Why did I say this? When we had this study many years ago, and from what I have seen, because we've been able to successfully deploy complete health information management systems in some facilities, private and even government tertiary institutions. And I'm always personally on the field, and we see what people go through, especially from the user hand, acceptability even from the patient hand, and then the stakeholders. There are different ways by which we can forestall failure and ensure that we don't make these things elephant projects. It's because many people believe that digitalization is actually very expensive, and some feel that it is actually not achievable. But I can tell us boldly today that it is actually achievable. All we need to do is ensure that whatever is being deployed to address whatever situation or case is given enough attention, and then you also have people who could stay with the users. Because if users don't flow along very well, no matter how beautiful your implementation is. It will fail at the end. And then it looks like it is not achievable. It is achievable, and I believe we can get there. Well, I have a screen here, which is one of the tools, one of the screenshots of the tools we used in collection of data when we had the study. Next slide, please. Thank you. Yeah, we have further important patient details that were captured on the field using handheld devices that goes remotely into the web server for data analysis at the head office. Yes, next slide, please. We also took data like diet and exercise, their addiction, their sexuality, the safety around them. You see, because when we talk of artificial intelligence, it works with what you have actually configured it to work as. For instance, what we did was we ensured that the artificial intelligence in the system works in such a way that once data is being captured directly on site into the system via remote devices, which were supported by broadband global area network. It's a technology which we use to ensure that we don't have internet failure because it connects directly to the sky. And I think there was a question in the chat box that talked about connectivity issues. A broadband global area network, which is a device with a size of a laptop, probably just about 10 inches or a little bigger than that, is good enough to give you internet access anywhere in the world. It connects directly to the sky, and the weather will not affect it in any way. So if you're in a remote location and you need to have direct access to internet uninterrupted, please, you can go for such device. And we also have many other of such that you could use. You can contact us later, and then we give us some of these devices that will help us in whatever deployment we are doing. Yes, next slide, please. Now, we also take addictions. I think I already mentioned this back then. We want to know their smoking habits. We want to know if they take any kind of alcohol, the liquid they take, how they smoke, the number of cigarettes per day, and all those things. You see, because all these factors are indications that will guide a clinical decision to present the presumptive to the clinicians and be able to address the best possible care to the pregnant woman. Yes, next slide, please. Okay, so this is a screenshot of a remote patient monitoring, which was used. Cranium Integrated Solutions Limited is actually a company that owns Cranium Complete Health Information Management System. And then this is the telecare module, which is used for remote patient monitoring. It's a powerful tool for pregnant patients with gestational hypertension. This condition requires regular readings of physiological data amongst other data, while remote patient monitoring makes it very easy to gather this data without necessarily having to physically visit any hospital, especially in this new era of different epidemics springing up by the day. Now, remote patient monitoring is seriously gaining grounds, and it is securing its permanency within our evolving healthcare system. And Cranium is one of the very effective EHR system with a telecare-enabled module to achieve this, as it creates platform for both patients and doctors to have seamless privacy-protected data and conversations with privileges to evaluate and examine present condition of the patient for continuous care. Next slide, please. Now, this is a typical screen of a remote patient monitoring and continuous care using a clinical decision support system, which is the CDSS. Now, how it works is you have all the data of the patient captured there, which are critical data that must be captured on the field. And then there's a module that works with the artificial intelligence that springs up presumptive, suspected presumptive for that patient based on the symptoms captured, the presenting complaint, and whatever data the patient gives to the data entry guys on the field, if you are actually in a rural setup. Now, if you are in any hospital physically, it also works such that as the clinicians take the data and then they input it directly into the system over time knows the kind of symptoms that if it is presented, the presumptive that should be flagged for such category, and then it flags it, and then the clinicians has the right either to go with the presumptive or to still want to check some other things. So there are different options by which clinicians can use to narrow down and be able to quickly intervene when it comes to preeclampsia and eclampsia in pregnant women. It also works for any diagnosis because we have the World Health Organization diagnosis and procedure captured in the system such that for every diagnosis, it has its own symptoms that would indicate and point to whatever presumptive that the system will flag. Next slide, please. Okay. Now, in summary, utilization of digital healthcare for early detection and treatment of preeclampsia and eclampsia in primary healthcare facilities will go a long way in reducing maternal deaths in pregnant women, and it will also help improve women's health and general well-being. Cranium has taken it as a major focus to ensure that deployment of this application is made to as many primary healthcare centers as possible across the globe. And then we know that optimum health in pregnant women is very important. And we have been soliciting support, collaborative efforts from all stakeholders, private and government, to join hands with us to achieve this global goal and make all our primary healthcare centers operate digital healthcare system for all pregnant women, at least for a start, to monitor antenatal risk and forestall possible maternal deaths. Now, there are many organizations springing up by the day. I think about 2 days ago, we were able to connect to, I think it's Bloom's Public Health via LinkedIn. They are actually in the core assignment to ensure that they give facelift to these primary healthcare centers, because primary healthcare centers, especially in Nigeria and most of the parts of Africa, they're already being pushed to the background. Meanwhile, their original reason for their existence is actually to intervene promptly without having to go a long way before you can have access to care. And I think people are really waking up to the call, and I believe by the time they get digitalized to a certain extent, they will be able to compete with standard hospitals, even in other areas in the world. Next slide, please. Yes, so in conclusion, information, education, and communication during pre and postnatal care is extremely important. The pregnant women are ill-equipped to make appropriate choices, especially when they are in danger. This contributes to persistence of high maternal mortality rates across the nations. Significant improvement must begin with fundamental recognition that pregnancy and childbearing are profoundly important events requiring carefully formulated social and health policies, as well as support from all stakeholders. I think it was just, was it yesterday or a day before, I saw the Vice President of Nigeria sign a bill to ensure that universal health coverage is achieved, probably I think by the year 2030, thereabout. Now we have many of these primary healthcare centers. If we will able to achieve that, then we must ensure that we focus on digital health. You see, because one of our speakers who spoke earlier on talked about when he went to a particular facility in Lagos and he saw a heap of files. There's a particular facility, I intentionally didn't want to bring the picture to my notes so that I don't bring things that are not supposed to be online. There are pictures that we wouldn't want to see. If you see pictures of where heap of patient records are being kept in our government hospitals, as a matter of fact, as a patient, you will originally believe, even when you step into the hospital, that this is not a place where you should be. You see, because when you have patient records flying indiscriminately in the hospital, it violates many patient confidentiality. But when you digitalize and your patient is sitting in front of you and the patient knows that, no, this is a new era. Originally, psychologically, even at that level, the patient already knows that there is going to be success. And so I want to charge us today to ensure we do all it takes in our own capacity and across our various specialties to support the move to reduce maternal mortality rates in remote and very remote areas across countries of the world using complete health information management system. And then I will drop this before I say thank you. When developing any telehealth system or EMR and EHR, it is advisable that you carry along health specialists. You carry along professionals in the health field, you carry along statisticians, you carry along everybody within the health sector, such that when this product is presented, it is going to be well designed such that it will not have any shortcoming. It took us about almost 12 years of development before we started projecting our product, because we carried along a lot of medical professionals in internal medicine, general medicine. We carried along health information managers, professional nurses. We carried along statisticians. We had the medical scientists and pathologists involved. We had almost all medical specialties involved in the development of our app, such that when it gets to the market and then it is being deployed at facilities, it will address the specific cases for which it is being deployed. So I want to drop my note at this time. I want to say thank you for this opportunity as I wait for that questions. Thank you so much.
Thank you. That was amazing. I do want to ask if you could clarify in the chat where you talked about the broadband and having access to broadband in the size of a laptop. If you can just put in the chat where people can get more information about that, I think that will be most beneficial.
Okay.
And I am so happy to hear about the new bill that was signed in Nigeria about the universal healthcare. Thinking about the argument, I don't know why it's an argument that is going on about if health is a right or if it's a privilege, which it should be a right. I think that having that universal healthcare kind of put that argument to sleep. If we are providing healthcare, at least the basic things of healthcare to our citizens, I think that that's important. And COVID-19 showed us that not only should healthcare be a right, but having reliable access to the internet is also critical, and it should be a right because it is critical and essential for modern living, from education to banking to healthcare. We have to be able to be connected and involved. What we're seeing going on in Ukraine and Russia with the lack of access to global information, how that is creating a lack of information and a lack of knowledge about what's happening on that side of the world as well. So I thank you for bringing that up. So our next speaker is Dr. Penny Overgaard. It is my pleasure to read her bio to you. She has worked as a nurse and a nurse leader in ambulatory settings for 25 years. She currently works as an assistant clinical professor at the University of Arizona College of Nursing. Dr. Overgaard has two major fields of research interests. One is health disparities, and the second is health and hunger. She has designed, led, or participated in numerous research projects. She is interested in factors that influence or create obstacles to health, particularly the role of trauma, including head injuries, adverse childhood events, and mental health, and the utilizations of a trauma-informed care approach as a framework for enhancing nursing care. She earned her ADN at Kishwaukee College in Malta, Illinois, a BSN and an MSN from Grand Canyon University, and she completed her PhD at the University of Arizona in 2018. Dr. Overgaard also has a particular interest in qualitative research design and the relationship between design and trustworthiness. She is active in projects that enhance care across the continuum for people with serious or chronic illnesses, and she is also a breast cancer survivor. So please please join me in welcoming Dr. Penny Overgaard. Did I need to share your slides?
Thank you. I'm so
Yes.
excited. I've learned so much. I've been busy taking notes and appreciate just being able to connect with everyone here. And also, you might notice, even though I don't know her, I actually received both my bachelor's and my master's from the same university that Dr. Etheridge teaches at now. So just very, very happy to be here. I'm going to talk just briefly to you about breast cancer screening. And I really like to highlight breast cancer screening as it saved my life, and it could save the life of so many women across the globe. So what is it? It is actually checking a person's breast for cancer before there are really any signs or symptoms of the disease. And I want to just make note that I have women's breasts here. Women are exponentially affected more by breast cancer than men, but both men and women could get breast cancer. And again, although screening doesn't prevent cancer, it can help find it early and make it easier to treat. So as we go to our next slide, part of this presentation is really to consider sort of what's new and what role that will telehealth help play in breast cancer screening. Now, breast cancer is really one of the most common cancers in women worldwide, and it's increasing particularly in developing countries where the majority of cases are diagnosed in the late stages. So a late diagnosis often means a poorer outcome. Our next slide talks about who should be screened, and really adult women. Adult women is usually defined as women or girls who have had the onset of their first menstrual period. And they should all be performing a breast exam at least monthly. Another important factor in breast screening is really to understand and know your family history. And also screening really needs to be part of a conversation and a relationship between healthcare providers and women, so that women can understand what's the best screening technique for them. On our next slide, I want to kind of go over our breast cancer screening tests. The self-breast exam, which is really a very, very important exam for women to know, to understand, and to talk to other women and encourage other women to do. A clinical breast exam, which is when a healthcare provider performs the same type of self-breast exam on a person. Mammogram and a breast magnetic imaging also. So let's move to the next slide and talk a little bit about telehealth and breast cancer screening. And I think what, at least at this period in our in breast cancer screening, the self-breast exam really becomes still one of the most important things that women can do, because on a video consultation, and we've heard lots about different ways that we can offer video consultations, but that physical assessment, whether it's part of a regular women's assessment, so your regular checkup, or a focused assessment because you found something in your breast, but that if you're doing this remotely, then really what happens is that the clinical or healthcare provider cannot perform the clinical breast exam, and that makes it even more important for us to know what we're looking for with self-breast exams, and also to have different types of mammography and ultrasound modalities available. And these can be done at home centers or very large centers, but increasingly we're seeing remote centers or mobile stations where people actually have the equipment and drive around in different vehicles to provide mammograms and ultrasound to women, or remote centers where the physician or healthcare provider is not present, but the exam can be done and the provider can look remotely at either the results or in real time as the exam's being done. And then breast magnetic imaging, which is still really confined to these home centers or larger centers, as it's a very heavy technology and also very expensive. On our next slide, let's talk a little bit about breast self-exam. So really we need to check both breasts and under both armpits, feel for any lump, thickening, hardening knot, or any breast changes that you can feel. And looking for dimples, sores, puckering, or changes, and also squeezing the nipples to check for discharge, crust, or lumps. And a little later in the presentation, I'm going to show you what I think is really probably one of the most wonderful tools for teaching women about how to do breast self-exam that I found that actually comes from the Nigerian Council on Breast Cancer. So our next slide shows us that since almost half of all breast cancers are found, early breast cancers are found when a woman discovers a lump in her own breast. So there's no replacement for this breast self-exam with any of the technology that we have. It's really about habit and what we encourage women to do self-care. And this slide also shows you some ways to actually do the breast self-exam. And there are many different ways that things that you can utilize, posters or actually videos that'll show you how to do breast exams. So I won't go into that since our time is a little bit short here. On our next slide though, what I want to show you is this slide that I've used when I talk to women, because I think it's just really a beautiful way to show that you can look and feel for all of these different signs of breast cancer, all 12 of them. And again, they're all here. The thickened area that a woman might feel, a dimple, nipple crust, red or hot areas, fluid discharge, again, skin sores, bumps, growing veins. Often people don't recognize that as a sign of breast cancer, but it can be a sunken nipple, a new size or shape, or a peeling like skin. So if a woman finds a change, and that's our next slide, that's the time that we need to reassure them that many lumps and changes are not cancer, but during those video or telehealth or in-person visits, that we need to go to our next step of screening, which is to use ultrasound or mammography to look a little bit closer at the changes that we're seeing. Remember, again, I can't stress this enough, finding cancer early makes it very treatable in most cases. And a healthcare provider will decide what types of advanced screening are most available. So that if you're in a rural area, we may not use the magnetic resonance, but we could start with an ultrasound or something that will give us an idea of the context and the severity of whatever's going on. Advanced screening, we talked a little bit about this, as the clinical breast exam. However, there's been several studies during the pandemic that showed that in the absence of that clinical breast exam, because of all the telehealth medication, medical appointments, that the self-exam was very effective. Even if the provider went ahead, talked to the woman or educated the woman on how to do the breast exam, and then had someone or the provider themselves checked back with the woman. So the clinical breast exam may not be as necessary as it once was in finding new cancers, but definitely something if it's an in-person video, if it's an in-person and not a video visit, that could be important. I do want to highlight, though, that as I looked across studies from the amount of breast exams or women who brought up breast exam in their appointments with physicians, it dropped during the early pandemic stages in some places from 40% to almost 76% in other areas. So what happened is without the physician bringing up breast exam and asking the patient or women about them at their video visits, it just went unnoticed and is seeming, all the evidence isn't out yet, but is really seeming to show that there was an uptick in breast cancer being discovered at a later stage than pre-pandemic times. The mammogram or the ultrasound is really just a closer look at the breasts looking using radiology. And then breast magnetic imaging is an advanced screening technique that we often use with once we know that there really may be some type of a cancer that exists there. So the last screen, I really want to just highlight again that even though we're doing more telehealth and we're doing a lot of different types of ways of screening people and using things at home, one of the most important things that we can do during these telehealth visits or in person is really talk to our patients, talk to our daughters, talk to our mothers and our friends, and teaching them and encouraging them to do breast self-exams, because even though we're using all kinds of telehealth and different types of advanced technology, finding that breast cancer early is one of the most important things that a woman can really do in terms of self-care to find the most common cancer affecting women across the globe. So thank you again for letting me talk about breast screening. Again, a very important topic to me. And I appreciate learning so much from all of you, as I do every time I attend these. So thank you.
Thanks, Dr. Overgaard. I really appreciate your presentation. I'm going to link the lemon picture down in the chat, because I think that this is a great tool, especially for women who may not have advanced literacy, just to be able to see the picture. I think will be very important as we're doing our outreach. So I appreciate that. So I'm going to link that in the chat for everybody to see. Remember, if you have questions, to put them in the chat or the Q&A, and then we will make sure that we get to those later. Right now, we're going to take a little bit of a pause, and we're going to invite the Chief Operating Officer for 1,000 Women in Religion for Global Peace, Dr. Ada Okika, to come and to provide some brief comments, and then we'll have our last speaker, Ms. Robinson Izozo. Ada, it's your turn.
Well, thank you, Portia, for a wonderful job you are doing, and thanks to the speakers that have been an excellent presentation on telemedicine, and this is what is most needed now across the world. I'm just going to reflect on initiative we are doing in regards to women and health, and this initiative was developed during the time of the post-2015 development agenda in 2015, when series of discussions were trying to review the Millennium Development Goals, which was enacted in the year 2000. Now, in the course of reviews on trying to evaluate the MDGs, the discussions were focused on, probably that was most of the forums I attended, were focused on the challenges and the gaps that occurred in areas of SDG 5 and 6, as well as SDG 3. Now, MDG 5 and 6, as well as MDG 3. Now, SDG 5 was talking about improved maternal health, combating HIV and AIDS, malaria, and other diseases, while the SDG 5 says challenges yeah, improving maternal health, 6 says combating HIV/AIDS, malaria, and other diseases. Now, these are focused on health concerning women, and MDG3 was on promoting gender equality and empowerment of women. So based on these discussions and forums, there were a lot of challenges and gaps. It came out to be that SDG 5 and 6 were not really achieved in the lives of women, especially when it comes to health. Statistics and data shows that women were more vulnerable to diseases, malaria, HIV/AIDS, other infectious diseases, and all the rest of them. And most of them lack medical and health maintenance strategies or skills. So we now came out with the initiative that we called My Sister's Health Watch. And this My Sister's Health Watch was as a result to explore possible ways to bring inclusive health to women, especially for women in communities. Because we take it that if these were challenges, data were shown indicating high figures on what women were, health of women and its challenges. We now felt that in rural communities, what about those women who were not used as this as the research study? What about those women who are not aware of all these things? Who are those women in rural communities who are subjected to a lot of community hard labor in trying to meet up with human needs? So that was what gave us the picture of My Sister's Health Watch. So having been in US for many years and then observing the way health is taken care of, being a priority. When someone is sick, you call it 911. The next moment, the EMS around you, medical team around you, and all the rest of them. You now wonder what happens, what is the situation, or what is the picture like on women in communities who don't have this kind of opportunity. So we see women health as giving high priority in these situations. Secondly, in developing communities, the reverse is the case. You either care by yourself or by your family. So we went into constant intervention, and you see that greater situation of in health services in community centers are not made available. A lot of communities, especially in developing countries, lack appropriate health centers, and even the ones available do not have complete health facility and even medical personnel. And these are challenges. The ones that are available, there's high cost of medical attention, which shows that you only go to the clinic when you have the money. And again, most of these people in health in communities don't have this money because you see the medical expert one. Secondly, you look for money to buy your medication. So a lot of challenges came out that most of these women had no opening for health attention, and that became a problem. And that is what gave back to My Sister's Health Watch. And then in bringing up My Sister's Health Watch, we consider the 3 P's of the SDGs. We looked at the P, which is the health of women and girls in the community. We look at the P, which is communities, rural communities, grassroots communities of developing countries. And then we look at partnerships where we can link up with global communities, health agencies, health institutions to see what best to do in the life of women and girls. So we had an action plan. Action plan was we took to make contribution into health policies. We consider the need of health policies, especially when policy just as the speaker before now, before the last, referred to the policies of the president of Nigeria on health. So such policies, we look at it and then see how we can develop advocacy document for community dwellers, community leaders, women who are positioned, who are well-to-do in a particular community, and discuss how best we can utilize this, especially women in government, women in legislature, like the Commissioner for Health, Commissioner for Women, where we can use them to help look into the situation of women in communities. We also took to advocating. Of course, policy and advocacy goes together. We also took to advocating, talking on behalf of these women. We also adopted professional development education for health practitioners. Those in those health centers, we try to give them professional development education to keep them in mind that these women are helpless when it comes to their health. And most of the outcome is that some of these women die too young. They die too young. You know, in one of the times we took a medical check into the market. You ask a woman, do you have blood pressure? You said, no, I've never had it before. It doesn't run in my life, blah, blah, blah. What about blood sugar? You say, no, no, no. The only thing I suffer is arthritis. And then you just check their blood pressure. You see high rate. The blood pressure is so high. And they are sitting under the sun, just with an umbrella covering their head for all day, trying to make ends meet. So in that center, work center in Edo State, we brought up these issues and tend to provide professional development education to some of these medical experts. One, we took into market women education. You know, because we found out that in the course of taking this outreach to the marketplace, in spite of the fact that their blood pressure was high, their nutrition style wasn't even helping in trying to help with their health situations. And they are not aware of that. And you know, in most African countries, there's this adage that says, it's the disease you know that kills you. So they don't really want to go into that kind of testing in order to know the situation of their health. Unlike educated women, when you wake up every morning before you get out of your bed, you test their blood pressure, you test their sugar, depending on what you want to test around before you get up. These people is not into their agenda. So we adopted this education, telling them the need and then helping them to, one, look into their nutrition, look into their health. But these are our challenges. One of the challenges is that you just say it at that moment. And when you go, it goes with you. Nobody follows up with it. There was no mechanism to follow up with them. And that was why we adopted the telehealth telecommunication health. In that telecommunication health, we try to follow up with them through discussions and follow-up. But these are challenges, are also equally challenging, because there are times you call on your phone, it's not available. So there was no consistency in following up with the health of these women in the communities. You know, even when we established my sister's health watch club in schools, it was still a problem, because when you go to that school, talk about the girls' health, how to take use of themselves, what to check in themselves, what they expect. Like my sister just talk about the breast cancer. These have been educated to them. Most of them can use some inner wears for 1 week, you know, or even 2 weeks without washing. Some of them don't even have enough inner wears. You know, maybe they can have just one, and you can imagine how far it will go because of poverty. You know, so some of these issues are compounding to the issue of our women and health, bearing in mind the composition of the women nature. So, as I said, our strategy, we adopted health education to communities on women's health. We go to marketplaces and then churches and women groups to talk about their health. But as I said, at that moment it lasts. After that moment it disappears. They go back to their lives. Of course, I said we adopted the teleconversation with health practitioners as well, telling them these areas of challenge, because when we deal with these women in the marketplace, and one thing with them, when you talk with them, they ask a lot of questions concerning their health, which means they are very confused with their health. So we move on to, of course, we have this specialized field of medicine and practice to help them into specialized schools. One of the things we adopted to get some of the community health practitioners to get them into specialized schools to help them improve on their education. But we are challenged because when you get them to some countries like India, South Africa, China, and Japan, once they have opportunity to go there, they don't come back. So the problem still continues. So, and what is our further action? We are currently developing a research proposal with a private university in one of African countries to establish a center for my sister's health watch for the attention of World Health Organization. Because in the course of when we launched this initiative at the United Nations, we had partnership with World Health Organization and some of the UN missions. And then we continued on that to develop this proposal. And this initiative is hoped to see World Health Organization partnership with focus on advocacy, SDG 5, and advancing SDG 5 on women and health. We are also through our partners in Sweden and in Australia with unique specialty clinic, organizing training seminars from hospital to hospital, community to community on operation of telehealth or practices and how best it could be applied to women's health in community. Currently, we are looking for sponsors to set up My Sister Health Watch Pilot Center in a community to use it as a telehealth center where medical practitioners can be connected and assigned to patients. Now, these are one of the things that we tend to hope to do, and we are believing that the My Sister's Health Watch will be strengthened in order to address some of these issues, because women's health is development, women's health is growth, women's health is sustainability. I thank you.
Thank you so much, Dr. Ada. You're so passionate about everything global health, and I really appreciate your remarks about what we're trying to do. Our next speaker is Miss Sylvia Latana Robinson Azizo, and it is my pleasure to introduce her to you. But before I introduce her, I just want to remind everyone, if you have any questions or comments, please make sure that you put them in the chat or the Q&A. And to our speakers and panelists, thank you for providing resources and answers in the chat. Please remember, we have an outstanding question about equity and equality. What is the best way to provide technology to people in underserved areas? So if you have any additional resources for that, please make sure you put that in the chat for the questioner. So Ms. Robinson Azizo is a global director for the chapter formation for the African Diaspora Development Institute. She is also the CEO and founder for Aveless Corporation, which is based here in the USA and is soon to open offices in Dubai and the Democratic Republic of Congo. Ms. Robinson was born and raised in Zambia, and soon after graduating from college, she moved here to the US. She has an excessively big heart for the continent and its well-being. Her Pan-African spirit reveals itself through her participation in causes that align themselves in advancing economic development and human capacity building in and out of the African continent. Previously, Ms. Robinson was host of an extremely popular US-based TV show, Africa Plus, serving the Washington, D.C., Maryland, and Virginia region, where most things African were the primary topic. She is not only a great diaspora community leader, but is an avid entrepreneur and motivational public speaker, mistress of ceremony, and she also was the director for the various pageants. She's a life coach, mentor for women and youth, and she is also a wife and mother of 4 beautiful daughters, 3 outstanding son-in-laws, a grandmother of 7, and finally, she is first and foremost a woman of God, a woman of purpose, and a woman of excellence. Ms. Ezizo, you have the floor.
Unmute yourself, ma'am.
Oh, sorry, I was talking to myself. I'm so sorry. Yes, thank you so much, Portia, for that introduction. What I was saying is I'm so overwhelmed by what I have heard, what I have learned, and what I have found out today from the previous speakers. Kudos to all of you. This is very, very important and juicy information that is very valid for those of us who are not actually directly involved in the medical field. But that being said, I'm not going to summarize everything that was said here today because I don't even know where to start. It's a very emotional thing for me because I deal a lot with women and with the young youth, the young women as well. Sometimes men, but mainly my mainstream is with women and the young ladies. I took a trip last year to Ghana and Nigeria. And what I saw in Nigeria broke my heart. The place where I went to is called Isoko, which is in the Delta region of Nigeria. To go to a normal big hospital, we had to drive 1 hour 30 to 1 hour 45, sometimes 2 hours with traffic. Without traffic, I think it's 1 hour 25. Even though I got to that hospital, the hospital itself was so dilapidated. We are taking COVID because, we had to take COVID tests upon arrival, of course, because all of us know about the pandemic. We had to wait quite a long time because the people that were doing COVID and the regular patients were intermingled, they were intermixed, very chaotic, but it was, I call it organized chaos. After we were taken in, believe it or not, in the same clinic, the clinicians start fighting among themselves. And they crisscross my husband's results with somebody else's because everybody's so angry at each other. And I'm sitting there and I'm looking and I'm like, is this really called for? The lack of equipment is what caused this sprawl between these two technicians. What the heck? My thing went off, baby.
We can see you.
Oh, okay. Well, it went off on my side. All right, if you can see me, then that's fine. So after that was said and done, we discovered that there was a mix-up with results. My husband's results and somebody else's results. We left and we went back to the house. The following day, we were invited to go to a church. At that church, it's an Anglican church. I did not get permission from the bishop to use his church name, so I'm just going to call it the Anglican church. When we got to the church, we were surprised to see how beautiful the yard was for where the church was built. To my surprise and delight, I'm not sure how the conversation started. My big mouth started talking about, I think, ladies and girls and whatever. And the next thing is the bishop is telling me, we have a nursing school. How do you have a nursing school in the middle of nowhere? According to me, it is somewhere, but for me, where we were is not like a central part of a major city. It's in the village, what they call a village. He took us to the school. Lo and behold, I thought I was in the United States. They have such beautiful buildings. They've built a very big school. I believe that school is going to house between 250 to 400 nursing students who are going to be educated from that premises. The best part about what I saw was right across from the new nursing school is Delta University, a 4-year degree university with PhD, of course. So he took us around this hospital, this facility, the nursing school. Everything is brand new. The buildings are brand new, looks exactly like I am in the United States or like I'm in a first world country, but it's isolated. It is not yet furnished. However, the buildings are beautiful. They took us around the school, has a big hall where we can party when we need to party, but the rooms were not yet furnished. No students are there yet. After we visited this school, I was really moved. And I had told myself, when I come back to the United States, I'm going to start asking for furniture for them to furnish their rooms and stuff and whatever else they needed. Upon us leaving the school, I believe my husband asked where was the closest hospital where the nurses who are going to be trained at that school are going to work. So he says, oh, the church owns a hospital too. The church owns a hospital, yes. How far is it? He says, oh, it's about 10 minutes from here. So for sure, we just jumped into our cars, drove another 10, 15 minutes, and we got to this other facility. Again, I call it in the middle of nowhere. When we got to the hospital, this was very, very, very surprising. He was very gracious. He opened every room at the hospital. We walked into the first office. There was a desk and a chair. Second office, desk and a chair. Third office, desk and a chair. We found 2 medical staff working. I believe one was a doctor and one was an admin. As we're going through the hospital, I see one nurse. Now I'm telling you, this hospital is a 200-bed hospital. One nurse that was on premises. There was a whole lot of patients that were waiting to be treated. So I asked the bishop, is it possible for me to look at your rooms? What do you have in these rooms? The first place he took me to was the theater, operating theater. I walked into that theater. I saw a bed that looks like a table, like a cutting board table, not a hospital theater bed, but like a cutting board table. I couldn't tell you the color. There was a cylinder of what I may call oxygen that had a contraption put on it, a long tube about that size. Then at the end of this tube, there's a funnel, literally the funnel that you use to pour oil or whatever in, that's hooked onto this tube. And then around it is rubber, real rubber, like the rubber band that we use to wrap papers. And that's what's supposed to go over somebody when they're being anesthetized. A small little rusty table was on the side of the theater. That big light, I don't know what you call it in the theater. I think it's supposed to have 5 or 6 bulbs. There was only 1 bulb. But people are having surgery done. There was one little bean plate with 1 scalpel and 1 little scissors that was so rusty. I asked the bishop, do you do operations in here? And he boldly told me, yes, we do operations in here. I got very emotional. We left. Went from room to room to room. We get to the maternity ward. The maternity ward has a brand new mama who just had a baby. The baby is wrapped in her, we call it a wrapper, a cloth that the mom takes off, and then, she wraps her baby in it. There are no dividers. There are other patients in there. I'm not sure where she gave birth at, whether it was in that room or another room. I didn't ask. My emotions were very high. There's no privacy. There are no mattresses on the beds. There are bed frames, all right, but there are no mattresses on the beds. There are no side tables for them to put their phones and stuff. Everything is in a little plastic bag on the floor. I looked at myself and I'm like, how is this possible? We have so much in the United States, so much things that they throw out. These hospitals throw out a lot of equipment that could be used here. So I turned to my husband and I said, you're sitting on a gold mine and you and I need to talk. You work for a facility that has hospitals and clinics and you guys throw out a lot of stuff. Is there any way that we can start collecting that old stuff from these hospitals? I don't care which part of the United States it is, but we need to start collecting this equipment, get some containers and ship them to Africa. First country is Nigeria. After we discussed that, he agreed with me and he says, yes, you're right. Every room that I went to, I'm telling you, there was nothing in the rooms. Nothing. No equipment for them to use. If there was, I was told, if you need surgery, you have to go buy your own stuff, your own scalpel, your own iodine, or whatever it is that you need for them to come and suture you, your own needles. How does that work? How does that happen? How does that happen? But anyway, I want to close on a very positive note here. We right now, with the help of the host of this program, Dr. Toyin Lawal, I swear this woman is something else. When you use the word dynamic, it doesn't begin to describe her. I don't know what word I can use for her, but for now I'll use dynamic, resourceful, enterprising, very big-hearted. She has helped us partner with UCLA. UCLA has given us equipment and we have filled up 3 containers of medical equipment that we will be shipping, probably 2 to Nigeria and 1 to another country. We haven't decided which country yet. So at this point, the reason I'm sharing this with you guys is because we need partnerships, we need synergies where we can figure out how to raise funds to start shipping these containers. As much as I would love to start shipping them with my own pockets, I'm retired right now. I may become homeless, but I need help. We need help. We formed an organization with Dr. Toyin and a few other people. We are now starting to fundraise so that we can start shipping, at least even if we ship 1 container per country per month or per every 2-3 months, it's gonna make a difference. It's gonna make a difference. The best part about this is the bishop had alluded to me to say they do have a program where if the inpatients or outpatients coming in cannot afford to pay for it, they subsidize it and they're treated for free. That was my condition to work with the bishop. I need those poor people, my grandma, my grandpa, and whoever else cannot afford to pay for medical treatment to be treated at that hospital for free. And he has agreed. Talking about telehealth, to my delight and surprise, out of every 10 people that I met, even at the hospital and out of the hospital, at least 9 of them have a cell phone. Out of every 10 people in Africa, at least Nigeria, Ghana that I saw, Zambia too, out of every 10 people, 1 person has a cell phone. So this telehealth tool will come in very, very handy for them. However, as much as it will come in very handy, is it affordable for those that can't even afford to go to a local hospital and get themselves treated? We have to figure out a way to marry our telehealth with also, if we can also work on affordability for those that cannot afford to pay for their medical, maybe their treatments, their medicines and stuff like that. On the other hand, we have another Dr. Toyin, I call her Dr. O. She has also agreed to help us facilitate to get some medicines, which all are going to be taken for a mission. We're going on a medical mission, hopefully by God's grace in November. I'm not from Nigeria, but I'm an African woman. I love my continent. Where my services are needed, I will go. Where my services are wanted, I will go. So I'm speaking to each and every one of you because our passion is the same. We want to help our people medically in the third world countries, or in the let me remove that word, less privileged countries. Because if we don't do it, nobody else will. So on that note, I'm thanking Dr. Toyin Lawal and Dr. Toyin O. Dr. O, both of them are Dr. Toyin, the first name. They have done a remarkable job, including my husband, Mr. Easy, Agrippa Izozo, who is the one who has orchestrated this whole thing to come together. We also have Dr. Aluya, who is also part of this team. So with that being said, I want to thank each and every one of you very much for being on this Zoom call. I have learned a lot from you, and I may be contacting some of you because what I heard made me very, very happy. And I've also become a new student. Like I was telling Doctor earlier on, I wanted to be my mentor. So with that being said and done, may God bless us all. And thank you so much for this opportunity.
Thank you so much. If you could please put your contact information in the chat so that people who want to donate to the organization can. That will be most helpful. I thank all the speakers who were with us today. I'm overwhelmed and full from everything that you've given us. And Dr. Toyin Lawal, I think the word that we were looking for is that she is the embodiment of the Proverbs 31 woman.
Amen. You're right. Amen.
That's
yes.
it.
Yes.
And
yes,
she
you got it.
is the woman after God's own heart.
Absolutely.
So, Dr. Toyin, I will turn this back over to you.
Thank you so much, Miss Moderator, Masha Portia, my sister from another mother, and thanks to all our speakers. Wow, I also learned a lot. I really sincerely appreciate every one of you. Thank you also to all our attendees from different parts of the world. A lot of people are actually watching us on Facebook as well. We have over like 700 people live on Facebook. Nice. So this is really very interesting topic and very engaging. Thank you so much. I will actually call on Masha Shola Ayodele to give the closing remarks, but my thanks to each and every one of you. Feel free to reach out to us, 1000 Women in Religion for Global Peace. And also, I think I put our information on the chat. And we look forward to the next action plan because this is the decade of action. We have to carry this to the next level. Thank you all. God bless you. Masha Ayodele.
Yes, thank you. I just wanted to say thank you to all the participants, both online and through Zoom. This has been a wonderful presentation. We started the day with Dr. Patricia Etheridge, and she started with a good overview of all the modalities that we have with telemedicine. She went from explaining the fact that technology is everywhere, and that has been a theme throughout this whole presentation, in which we all are wondering how we could use technology to improve the health of women. She also described not just because technology is there, but the fact that there are pluses and negatives with telemedicine. She was able to explain how COVID-19 has helped with the adoption, increase the adoption of telehealth. Then we move on to Mr. Okai. I hope I'm pronouncing his name properly. And he explained the differences between equality and equity, and how the discriminatory practices that are embedded in some of the health institutions throughout the world. And finally, he's talking about the fact that with liberation and inclusion, all parties will be represented. And just like the first speaker, how wearables are an important part of telehealth, and that the future of medicine is digital health. Then we had Jacqueline Williams, who explained why telehealth was very important to women, and how telehealth education could be another way that more people could be educated and not have to go to the hospitals, and how it could solve some of the geographical impediments that we may have regarding access to healthcare. And then we also had engineer Kunle Adeshida, who was able to explain how a study between Nigeria and Canada kind of gave birth to his participation in digital health, and how digital health and artificial intelligence could help with presumptive diagnosis. I cannot tell you as a Nigerian how many people are here, half of the time they would end up dying, and all we would hear is that they had malaria or they had typhoid. And with a program like this, I think it would really help with better diagnosis. We also had Dr. Penny Overgood, who is a breast cancer survivor, and so am I. And so this is very important to me. This was one area that I never thought telehealth would do, but it definitely opened my eyes to see what telehealth could do in the area of breast cancer screening. And Ms. Robertson, you explained and shared your emotional recount of your experience in Nigeria, and it's called all of us to help with getting better health care to the people of Nigeria and Africa as a whole. And I noticed in the chat that Engineer Kule has agreed, I don't know if you saw that, to be able to provide health, the cranium services 100% free to this hospital. So a lot of great things are happening. I appreciate it. Dr. Lawal, an amazing, smart, intelligent, dynamic. I don't know how many words are in the dictionary to describe this wonderful woman of God. I call her my friend. I call her my mentor. She's an amazing woman. I want to say thank you to all the participants. I hope we would get to see more actions through this program. On behalf of 1,000 Women in Religion, Tabernacle Worship and Prayer Ministries, thank you. I'll turn this over to Portia.
Okay, thank you so much, everyone. To keep in touch with us, I did put our email address in the chat box. That is 1,000 Women in Religion for Global Peace at gmail.com. 1,000 Women in REL for Global Peace at gmail.com. Okay, so this concludes our program for CSW 66. We get to see y'all in person next year.
New York next year.
Bye, everyone.
Thank you.
Yeah. Thank you. Thank you, Dr. Ada. Thank you.
Awesome.
Thank you all, and thank you for the opportunity.
Thank you, sir. I will be waiting for your email, sir, because I still needed to report to the UN. Thank you.
No problem. I actually sent it to one of the mails you used to send to me. So
Okay, I didn't
yes,
get it. It's
yes.
okay.
I mean, later you find it. Yeah. Thank you.
Thank you. Thank you, Engineer Kunle. Thank you for.
Thank you.
Good night.
Bye-bye.
Toy, and I removed everybody.
Oh.
Is there anything that you need me to do?
No, that's good. I just need to make sure I get the recording. Thank you, son. Thank you, Mr. Adegoke. I just want to make sure I stop the recording. I missed the recording for my session. I didn't press record, but it's okay.
Oh, okay. So yeah, just hit stop recording. And did you turn off Facebook?
Yeah, I will do that now. Stop like